Sorry. Good afternoon. My name is Charlotte, and it is my pleasure to introduce to you our speaker for today, Dr. Tony Scialli, who many of the happy students are already familiar with as our lecturer for our Theory and Methods course. Dr. Scialli has informed me that he likes short introductions, so I've kept this brief. As well as being a consultant and specialist in reproductive and developmental toxicology and obstetrics and gynecology, Tony is also a professor at Georgetown University Medical School, specializing in obstetrics and gynecology, as well as at George Washington University School of Medicine and Health Sciences. You could say he is a rather busy individual. When he isn't consulting, lecturing at both of these institutions, or harassing obstetrician gynecologists about their medical practices, Dr. Scialli enjoys writing musicals. Hopefully one day he will have a Tony Award to match his name. I, for one, am really excited to learn more about the medicalization of women's health, and I'm glad that being a woman is not a disease. Welcome, Dr. Scialli.
Well, thank you, Charlotte. That was wonderful. So today I'm going to talk about these 4 topics, and I think you'll see where I'm going after a short while. We'll start with menses. So it's very natural for a gynecologist to talk about menses, but most other people find the subject to be embarrassing or awkward in some way. And we have a long tradition, certainly in our society, of regarding menses as unclean or in some way unholy, and also of regarding the hormonal changes and the associated psychological changes as making menstruating women in some way unstable. In fact, when I was in training, which granted was a million years ago, it was common to say that women should not be judges, surgeons, or airline pilots, because what would happen if during a menstrual period they went berserk and drove the plane into a cliff? Believe it or not, this was not a joke. It sounds like a joke now, but that was an argument for disqualifying women from important positions. And here is an example from one of our traditions. This is a rabbi blessing a mikvah. As some of you know, in the Jewish tradition, menstruating women are considered unclean. They are not permitted to come into the temple. They are not permitted to have intercourse with their husbands until they have been ritually cleaned in a bath at the end of their menstrual periods. Now, this produces quite some inconvenience, as you might imagine. I had a patient once who came to see me for treatment of infertility, and it turned out that her problem was that her menstrual period lasted quite a long time. She had bleeding quite a long time into the first part of her menstrual cycle, and in fact was usually unable to have intercourse near the time she was ovulating because she was still spotting at that time and had not been to the mikveh. This was a very difficult problem because anything I did to change her menstrual pattern would probably also interfere with ovulation. We now know that it is okay for women to be surgeons and to be airline pilots and even Supreme Court justices. So we no longer pay as much homage to the idea that menstruating women are unstable, although I would suggest that there are still quite a number of people in our society who regard menstruation as being a time when women might be susceptible to acting crazy and doing things for which they could not be held responsible. So we've gotten a little bit away from that, but there still is that taboo associated with menstruation. Largely in our society, menstruation is a source of income for companies that sell products meant to assist women with the discomforts of menstruation. So here we have an advertisement for a menstrual product designed to keep menstrual blood from messing up a woman's white tennis outfit. And in fact, this is quite a symbolism loaded advertisement. So here we see Serena beating Mother Nature. She has shut out Nature's monthly gift. There's Mother Nature in green holding her monthly gift, which is discreetly pink and not red. And here are the male security guards preventing Mother Nature from coming in and messing up Serena's white outfit. This is my favorite advertisement for a menstrual product. This is the whole advertisement. These are the only words on it. Tampax Compact. And you can see the message very clearly. If you're going swimming in shark-infested water and you're menstruating, you better have a reliable method of keeping the sharks from smelling your blood. And I don't know how well this advertisement did, but I bet that the company knew very well how much product this advertisement sold. Perhaps a little bit more pernicious are the advertisements for medicinal products for symptom relief. So we have the over-the-counter products such as Pamprin and Midol, which contain pain-relieving agents, some mild diuretics to relieve the bloating that can be associated with menstruation, and calcium, which has been shown in some trials to decrease the psychological effects or the mood effects of menstruation. But then we also have prescription medication, which I would suggest is perhaps the most pernicious advertising of them all. And so drugs that have been used to assist women with unpleasant mood symptoms include benzodiazepines, which is a class of drugs that includes Valium and Klonopin and lorazepam, and fluoxetine, which is otherwise marketed as Prozac. And this is an interesting story about our drug approval apparatus. By the way, just to show you that Sarafem does appear in the market in other countries. So it's not just a US phenomenon. And it's used officially to treat what's called premenstrual dysphoric disorder. Now, premenstrual dysphoric disorder is actually a made-up disease. It was created by Eli Lilly and Company, a pharmaceutical company. And it was created in preparation for Prozac coming off patent. So if you're a healthcare provider and you write a prescription for Prozac, the pharmacist is permitted to substitute generic fluoxetine for the Prozac because it is available generically, unless you indicate on the prescription blank that it can only be dispensed in the brand name. The company that makes it will not benefit from your prescription. However, the new drug marketed for premenstrual dysphoric disorder called Sarafem had an extended patent life, because if you take an existing drug product and you come up with a new indication, you can get an extension on patent life for that drug. In order to come up with a new indication, Eli Lilly had to invent a new indication, and here it is. So this was first enshrined in the DSM-4, the Diagnostic and Statistical Manual of the American Psychiatric Association. And here are the criteria in the DSM-4. You have to have the first 4, and then you have to have some smattering of the next 7. Now, if you read through this list, I think most of us, men and women, would qualify as having premenstrual dysphoric disorder at times. And so depressed mood, anxiety or tension, affective lability. Affect means mood, lability means you're all over the place. Irritability. Anybody here whom that does not describe, at least at some points? So with a definition or with criteria this loose, it's not surprising that women would come to their physicians or other healthcare providers' offices and said, I hear there's a new drug for my premenstrual syndrome, which is now called PMDD. The other thing that happens as a consequence of menstrual discomfort is physicians and other healthcare providers will not only control it with hormones or medicate it, but women may also be offered surgery to remove the source of the problem, namely the uterus and the ovaries. Interestingly enough, if you just remove the uterus, and that's called hysterectomy, and you leave the ovaries, some of the cyclic symptoms can persist. So doing just a hysterectomy may not solve the problem. You can remove the ovaries as well, and that will cause the woman to be immediately menopausal, and that is a sure cure for menstrual-associated symptoms. I would suggest, however, that it's excessive. Hysterectomy is not a benign operation. There are risks associated with it. Certainly there are discomforts associated with it. And there are medical consequences of castrating a woman, by which we mean removing her ovaries. Now, that should not be taken to mean that I don't believe that women who are uncomfortable with their menstrual periods do not deserve to be offered treatment. And there are a variety of treatments that can be offered to women who have uncomfortable menstrual symptoms. And I'm not going to go through the whole range of treatments that can be offered. But the point is that menstruation is normal, it's not a disease. And the treatments that are given or that are offered are meant to assist the woman with discomfort and not to cure her of an important medical problem. I'm going to turn now to having a baby. Having a baby is usually as difficult as falling off a log. It happens without people thinking much about it. They get pregnant, they go through pregnancy, they have babies, and it's not a disease. However, healthcare providers who take care of pregnant women, at least in our society, have been accused, and I think rightly so, of turning pregnancy into a disease that's cured by delivery. And so I'm going to turn to labor and delivery. So the process of having contractions that result in delivery of the baby. And I'm going to address what's normal about being in labor and having a baby. Well, of course, everything is normal about it. But here are some of the things that people have identified as potential problems in having a baby. So we start with the long latent phase. What does that mean? Well, the cervix, here's a baby's head. This is the cervix, which is sometimes called the mouth of the uterus, which is a couple of centimeters long and which is closed up, meaning the opening is not very large. And this is what I want you to pay attention to, the length of the cervix that is blocking the baby's way out. As labor continues, as labor occurs, this tissue, which is fibrous tissue, it's connective tissue, gets pulled up into the lower part of the uterus. So you can see that happening here. We estimate the extent of that process with a term called effacement. Effacement is the thinning and shortening of the cervix as the tissue is pulled up into the lower portion of the uterus. So here's a cervix that's 0% effaced. Here's a cervix that's 50% effaced. This cervix is completely effaced. All of the cervix has been pulled up into the lower portion of the uterus. Now, the cervix isn't going to dilate. That is, the opening is not going to dilate much until the cervix has been completely effaced and there's not much tissue left. You can imagine it's easier to dilate this kind of cervix than it is to dilate this kind of cervix. The process of effacement takes a long time. For a woman having her first baby, effacement can easily take 12 to 24 hours, during which she's having labor pain, she's contracting, she's excited, maybe frightened, maybe alarmed. And during that period of time, there's really not very much going on besides the cervix just getting shorter and thinner. So birth attendants need to be patient, and they need to educate their patients and their patients' family and friends to be patient because it takes a long time. As some of you know, women in our society are often quite frightened of labor. They've heard that it's extremely painful. They've heard that you lose control during labor, that you go a little nuts, that your temper is short. I have to confess, I've never been in labor, but I've certainly taken care of a lot of women who are in labor, and certainly they react very differently. The key is that with appropriate education, with appropriate reassurance, the latent phase doesn't need to be a time of misery. And in fact, the best plan for the latent phase is let the woman stay at home, let her walk around, let her eat, let her do whatever she likes to do. Putting her in bed in the hospital is the wrong place to put a woman in the latent phase of labor, because it fosters the idea that she has a problem that requires admission to the hospital. And this can be quite alarming or at least intimidating to a woman. Those of you who have been in a hospital or who have worked in a hospital know that hospitals are not very friendly places. They can be very off-putting. So keep women out of the hospital, certainly during the latent phase of labor. After the cervix shortens and thins, there's active dilatation of the cervix. The opening in the cervix gets wider, but even that can take a long time, and we'll show that in just a minute. Then the woman, after her cervix is complete, pushes the baby out. That can be hard work. The baby's head descends, and the baby's head goes through a number of different maneuvers to negotiate its way through the pelvis. And here are some of the maneuvers. I'm not going through this in detail, but what's interesting is that these so-called cardinal movements of labor are no longer taught. In other words, people training to become obstetricians don't learn about the normal physical things that the baby's head needs to do in order to negotiate the pelvis, which, in my opinion, being an old person and wedded to the past, is a disadvantage for treating the labor process as normal. Now, this curve is called Friedman's curve, named after Emanuel Friedman. Emanuel Friedman is still alive. He is still writing letters to the editors, complaining bitterly about how backward obstetricians are. And what Manny Friedman did in describing this curve was to have something named after him while he was still alive. That's really quite unusual. In any case, Friedman's curve describes an average rate of dilatation of the cervix. So this is time, this is centimeters of dilatation, showing that labor doesn't produce much dilatation at all to begin with, and this is the latent phase in here. And then the dilatation becomes more active. So this phase is 12 to 24 hours in a woman having her first baby. This phase is about 1 centimeter an hour. And then things slow down near the end as the woman pushes the baby down and the baby's head has to go through all those motions in order to negotiate the pelvis. Friedman's curve is sometimes politely called an abomination. Why is it an abomination? Friedman's curve is an average. And what that means is that Manny had his residents collect data from lots of women having normal labor and delivery, lots of normal women. And those curves, some went like that, some went like that. They went all over the place. And Manny drew a line through the middle. So Friedman's curve is an average. Unfortunately, obstetrical providers used to be taught that Friedman's curve was important and that if you fell off Friedman's curve, it meant something bad was happening. So here is falling off Friedman's curve. You can see that a woman gets up to, say, 5 centimeters, and an hour or two later, she's still 5 centimeters. She has fallen off Friedman's curve. When I was in training, again, we had gas lighting in the hospital, and we were taught that a woman who fell off Friedman's curve for 2 hours, we gave her 2 hours to jump back on, was in trouble, that it meant the baby wasn't going to fit. And so we were taught that if a woman fell off Friedman's curve for 2 hours, you needed to consider cesarean section. Well, in fact, we know that if you just leave the woman alone, or maybe attend to her discomfort, that she will pick up again and join the average or approach the average. Doing a cesarean section on a woman who falls off Friedman's curve is like amputating a portion of the legs of a woman who's taller than average. We don't tell tall women that they have fallen off the height curve and therefore they need to have corrective surgery. What causes this kind of delay or falling off? Well, sometimes it's because the uterus and the woman are exhausted and need to get some sleep. So what used to be done many years ago in the UK is to sedate these women, to give them some morphine, put them to sleep for 2 or 3 hours, let them get some rest, and when they woke up, they'd be in better labor. However, that's not done so much now, although it sounds very humane. What's done now is if they're not having adequate labor, we give oxytocin, which is a hormone that causes uterine contractions, to make their contractions stronger. And that's okay, we can make the contractions stronger. But what's actually going on is the baby's head is molding, changing its shape in order to fit through the pelvis. So the bony pelvis is somewhat restricted. Now this is a baby's head looking from the top. These are the skull bones. They're not attached to one another. It's not solid. In all of us, the skull is solid bone. But in fetuses, there is space between the bones so that the bones can move with respect to one another and change shape. Molding is normal, but molding takes time. So as the head gets into the restrictive area of the pelvis, molding takes some time to develop before the woman can rejoin Friedman's curve and have a happy ending. Electronic fetal monitoring. Electronic fetal monitoring was invented in the late 1960s. It became widespread during the 1970s. I was training in the late 1970s, and fetal monitoring became routine. Fetal monitoring is important. It's important because it is a major cause of cesarean section. Now, just to orient you, these represent contractions. So this is a tension monitor that's put on the woman's abdomen, and it senses the tension being developed by the uterine muscle. When the uterus contracts, the muscle gets tenser. That's what all muscles do when they contract. If you don't believe me, make a muscle and feel it, and the muscle is tense. And that's sensed by this tension sensor that we strap to the woman's abdomen. This shows the heart rate of the baby. The heart rate of the baby is normally between 110 and 160. It will be higher when the baby moves. There's variability in the heart rate. It's not the same from one moment to the next. This is a normal fetal monitor tracing. This fetal monitor tracing, however, shows compression of the umbilical cord. So we see the fetal heart rate dip down and come back. Here's a milder deceleration. And the key to these decelerations is the onset is rapid and the recovery is rapid. Now, I'm not going to go into the details of the physiology, but this process is normal. This is normal. What happens with compression of the umbilical cord is that the umbilical veins which are shown in, the umbilical vein is shown in red here. It has oxygenated blood from the placenta. It goes back to the baby into the right ventricle. With compression of the umbilical vein, there's a decrease in filling of the right ventricle, so a decrease in blood coming into the right atrium in a given period of time. So the heart has less blood to pump. As a reflex, the heart rate slows down in order to allow more time for the heart to fill. This same process happens in you and me. If there's a decrease in the return of blood to our right atria, our hearts also slow down to permit more time for the heart to fill. That's not because we're sick. It's not because we're in danger. It's because it's a normal physiologic reflex. Reflex meaning mediated by the nervous system at the speed of light. Hence, the sharp decrease and the rapid recovery when blood flow returns to normal levels. This is not a sign of the baby's brain dying. And yet, if you look at that, you might say, oh my goodness, this is something catastrophic. You might say, we need to rescue this baby. In fact, what you need to do is nothing. Or as I was taught in my residency, don't just do something, stand there. That's a joke. So we see these misinterpreted heart tracings as the cause of considerable mischief in obstetrics. And so here's one woman putting a fetal monitor on another woman, making you wonder whether, in fact, fetal monitoring ought to continue to be used. In fact, in the 1970s, after fetal monitoring had been used for some years, NIH appointed a panel to consider the question of whether fetal monitoring ought to be routinely used. And the panel decided, no, it ought not to be routinely used because it did no good and it potentially did harm. Doing harm meaning causes cesarean sections. That report was squelched by the American College of Obstetricians and Gynecologists. That's our professional guild, because there were no obstetricians on the panel. That was perhaps impolitic of the NIH, but I can see why there were no obstetricians on the panel. Obstetricians were largely biased that new technology must be good. So we have to consider whether in fact fetal monitoring should be used. There are other ways of keeping track of the fetal heart. They require more attendance in the labor room, so they are not as cost effective as a fetal monitor, but in the long run, they may be more cost effective by preventing overinterpretation of fetal monitor tracings. What do we do when a woman comes into labor and delivery? Well, the typical routine, these are typical routines that used to be used absolutely all the time in this country, are now used less often, but only to some extent. So NPO means you don't let the woman eat or drink anything. Now, if you think about it, that makes absolutely no sense. Women in labor are laboring, they're working. They get hungry and thirsty, they get hot and tired. Why can't they have something to drink or something to eat? The rationale was that a woman in labor should be regarded as an incipient cesarean section, as a woman who was a candidate for having major abdominal surgery. You wanted the stomach to be empty in a woman who is going to have major abdominal surgery. That, I think, is a bad attitude. If you're treating women in labor, who, remember, my premise is that they are fundamentally normal, if you're treating them like candidates for incipient major abdominal surgery, I would suggest you have a bad attitude. So more and more practitioners have been willing to let women eat and drink. In fact, right now at George Washington University, which is the last place I delivered babies, it was becoming routine to let women have clear liquids. Clear liquids are water, apple juice, basically broth, basically anything you can see through. And the reason was that clear liquids would pass through her system more quickly, and therefore her stomach was less likely to be full when you took her for a cesarean section. In fact, in many midwifery practices, women can eat whatever they want. Most women in labor don't want to eat very much because the stomach doesn't empty very well in labor. The uterus is hogging all the blood supply. And so women feel full and bloated if they have spaghetti and meatballs when they're in labor. However, they certainly get thirsty and they drink a lot. So what can they drink? Anything they want. And in order to prevent the full stomach at cesarean section, just don't section them. It seems to me that's an obvious answer. IVs, intravenous lines. So intravenous lines are meant to hydrate a woman since you're not allowing her to eat or drink. But intravenous lines can also be restrictive. Women labor better if they're up and around. If they're walking or standing or sitting in a hot tub or standing in the shower, they don't labor very well when they're tied to the bed by an intravenous line. What had become more routine practice at GW when I was last there is that the staff would start an IV, but without the bottle and the tubing. So just the IV catheter in the woman's arm plugged off so she wouldn't lose all her blood on the floor, and just there in case of emergency. Okay, I can't argue too much with that. Women being confined to bed used to be absolutely routine because you can't monitor a woman when she's walking around. The cords from the monitor to the belts on her abdomen don't go that far. More recently, there are ambulatory monitors, that is, belts on the abdomen or devices on the abdomen that communicate with the monitor by radio waves or Bluetooth or something like that, so that women can be walking around at least within a certain distance from the receiver while they're in labor. But women should be encouraged to be out of bed, to be walking around, to be doing what they're comfortable doing, which is usually not lying in bed. Finally, we have epidural analgesia. Now, as I said, I've never been in labor, and I'm certainly not going to deride the practice of offering an epidural for pain relief. Epidural is probably the most effective reliever of labor pain. In fact, most women with a good epidural have no pain whatsoever. At the same time, what happens with an epidural is that a catheter is placed through her back into the space around the spinal cord, and a local anesthetic and an opioid is like morphine or a similar pain relieving agent, are injected. That causes very good pain relief, but the local anesthetic causes a paralysis of nerves going to the muscles. So women become either weak or paralyzed in their lower extremities, in their legs, and sometimes in their lower abdomen and pelvis. This will interfere with pushing. A woman with an epidural doesn't push as well, if she can push at all, and it certainly can interfere with walking since she has no control over her legs. These problems have been addressed by different formulas injected through the epidural catheter, formulas with a more weak solution of the local anesthetic and a higher concentration of the opioid. And there are some epidural techniques that interfere with labor processes less than others. But keep in mind that there are other methods of pain relief, and there is no rule that a woman must have complete relief of her pain. The answer is to involve the woman in the decision-making about her choices, if she has any choices, for relief of pain. Commonly, this question is addressed in prenatal classes, but it's unusual that the obstetric provider will address the question in any detail when a woman is in labor. When a woman is in excruciating pain, that's probably not the best time to bring up the options. It's probably better to do it well in advance when the woman can consider her options and their potential drawbacks. So I am not against epidural, but I am against epidural just being given without any thought to what it might do to the labor process and without any involvement of the woman in the decision-making. All right, finally, I'm going to come to the elephant in the room, which is cesarean section. This graph shows the cesarean section rate in the United States from the 1970s, when I was in training, until 2007, which is the last year that was collected for this graphic. And what you can see is the cesarean section was 5.5% early on. Now, the cesarean section rate used to be 0. The reason is that prior to antibiotics and blood banking and modern anesthesia techniques, cesarean section had a high mortality rate. That is, women died from cesarean section. Women still die from cesarean section, but the death rate is much lower. It's about 60 deaths per 100,000 women. So that's not 0, but it's much lower than it used to be. As cesarean section became safer, it became more common to use it in certain situations. And for reasons that I'm not going to detail here, the cesarean section rate of around 3 to 5% appears to be justifiable. And let me put it this way, at GW, and I'm sorry I'm leaving Georgetown out of it. I haven't delivered a baby at Georgetown since the 20th century, but I have delivered babies at GW more recently. So I don't really know how things are at Georgetown, but they're probably the same as at GW. And at GW, there's a midwifery group, which is very good. Midwives are birth attendants who are well-trained, who are very knowledgeable about how to assist women delivering vaginally. And the midwifery group at GW has a cesarean section rate of between 3 and 5%. That's probably a reasonable cesarean section rate to accept. But you'll see that in the 1970s, and I started my residency here, 75. I finished my residency in 79, so I was on a pretty steep part of that curve. That was associated with two changes that, in my opinion, led to that steep increase in the cesarean section rate. The first was that women expected their doctors to be in the hospital when they were in labor. That came to be the expectation. Prior to that time, when I was in medical school in the early 1970s, and I went to medical school in Albany, New York, which was not as advanced as George Washington, but for those of you who haven't been to Albany, New York, they do have flush toilets and incandescent bulbs now. But at the time I was in medical school, the doctor never came to the hospital until he was called, and doctors were all men at the time, so I can say he, until he was called by the labor and delivery nurse. Labor and delivery nurses were all women. The labor and delivery nurses had to be expert in knowing how long it would take the doctor to get to the hospital. Because if the nurse called the doctor in too early and he had to wait, he would be furious. He would be absolutely beside himself. So they became very good at knowing how far away a doctor lived, or whether he might be sleeping at his girlfriend's house or whatever. And so they would call at the last minute. The doctor would show up, wash his hands, put on some gloves, and deliver the baby. However, not long thereafter, doctors would have to be in the hospital. Labor normally takes a long time, a very long time, many, many hours, and doctors would get impatient. When a doctor gets impatient, he or she is more likely to say, well, this labor is just not progressing very well, and we'd better do something to rescue the baby. The other thing that happened during this time period is fetal monitoring was becoming widespread. As I said, it was invented at the University of Southern California in the late 1960s. And by the time I started my residency in 1975 at George Washington University, every woman in labor had a fetal monitor, every woman in labor without exception. And we've seen how overinterpretation of the strips might lead to a cesarean section. And here's the proof. Now, you'll notice that in the 90s, there was a dip in the cesarean section rate, which in this country reached a low of a little over 20%. A little over 20%, still 4 times what's probably a justifiable cesarean section rate. And the idea of letting a woman labor and deliver vaginally after a previous cesarean section was taking hold during this period of time. However, it became discredited because of the risk of the uterus rupturing. Once a uterus had been assaulted with a sharp instrument, it was more likely in a subsequent labor to rupture open during labor. uterine rupture can be catastrophic. And so doctors became gun shy and declined to permit women to have a trial of labor after repeat cesarean section. Now, I say it in that way intentionally. Doctors refused to permit women to have cesarean section, to have labor after cesarean section. But of course, doctors permitting women to do anything is an archaic idea. Women can do whatever they want. Doctors can't permit or prohibit anything. I would counsel women who had been told they must have a cesarean section that no, there's no imperative. There are risks, there are benefits. You make the decision. And if the doctor doesn't permit it, let him find another doctor for you, or let him just deliver you and put up with his personal discomfort. In any case, as you can see, by 2007, the cesarean section rate was much higher than it had ever been, at almost 32% in this country. Today, I'm sorry to tell you, the cesarean section rate is 35%, so it is still going up. And so I think that's much too high. It's hard for me to imagine that Mother Nature is so stupid that it requires that 1/3 of babies be delivered by major abdominal surgery. All right, so what are the potential reasons to do a cesarean section? There's a couple of dozen of them, but here are the three most common. Failure to progress, meaning falling off Friedman's curve, which is often just failure to wait. Non-reassuring fetal heart tracing, which we've seen is highly suspect. There are fetal heart rate tracings that indicate a problem. They're not very common, but they do occur. And previous cesarean section. The first two are the most common reasons given for cesarean section. So why would a woman not undergo a trial of labor? And there are two reasons that are given. One is that the uterus might rupture. Absolutely. The uterus might rupture. Uterine rupture during labor can be catastrophic for the mother and the baby. It is a terrible complication. In 40 years of doing obstetrics, I've had one patient with a ruptured uterus. So it's not very common, but it's not zero. And in fact, the national statistics are 0.5%, 0.5%. So 1 out of 200 women who has a labor after she's had a previous cesarean section, 1 out of 200 women will have a uterine rupture. Often we have reasons to suspect uterine rupture before anything catastrophic occurs. And so in the case that I had, we suspected uterine rupture before anything bad happened. We did emergency surgery, rescued the baby, who did fine. The mother had some extended surgery because the rupture did some more damage in her abdomen, so it was not a wonderful outcome for her, but in the end, everybody did fine. So even though it can be catastrophic, it doesn't have to be. My practice was, in a woman with a previous cesarean section, to recommend that she consider trial of labor and to tell her that uterine rupture could occur, would be catastrophic, and that the prevalence of uterine rupture was 0.5% or 1 in 200. And of course, she would be permitted to make the decision. The other potential downside is she might fail to deliver vaginally for some other reason. Maybe the baby wouldn't fit, or maybe something else would happen. In practice, failure to deliver vaginally depends more on the attitude of the birth attendant than on the anything else. So in some hands, for example, when I had a woman who was laboring after a previous cesarean section, she almost always delivered vaginally because I didn't use Friedman's curve. I took fetal monitoring with a grain of salt, and I basically left her alone. The midwives at GW do trials of labor after cesarean section. theirs are usually successful as well. So the attitude of the attendant is probably the most important piece of the success rate. Here are the risks of cesarean section. So remember, this is a woman who's considering it. You need to tell her the risks of both options. So risk of cesarean section, they're not really very good. Now, if you add up the risks of all of this stuff, the first four are immediate risks, things that might happen in the woman's hospitalization. And the prevalence of those complications in a woman who has had a cesarean section is approximately 0.5%. So about the same. So as a mathematical puzzle, the offsetting risks are similar between trial of labor and a repeat cesarean section. But future fertility can also be impaired, especially the location of the placenta. What happens is that after a cesarean section where the incision is made here, the placenta is more likely to implant, to be located over the scar. That's called the Placenta Previa, which is Latin for the placentas coming first. This is not good. This can result in bleeding, premature delivery, premature separation of the placenta. And in some instances, the placenta will invade the uterus to such an extent that the uterus is in fact ruined, destroyed, and sometimes the woman dies as a consequence of this extensive invasion of the placenta. When you count all of the stuff that can happen in future pregnancies, the mathematics becomes a little bit easier to interpret in favor of a trial of labor. But the fact is, you don't need arithmetic to decide which is better. Having a vaginal delivery is, in general, more pleasant for a woman, more pleasant for her family and her companions than is having major abdominal surgery to deliver a baby. Well, clearly the decision needs to be made by the woman, but this requires substantial education. That education should be done early during prenatal care, if the woman comes for prenatal care, or early in the course of the labor. All right, so why are obstetricians so backward in their management of labor? And I consider them backward. These people on the slide are not backward. They just come from a different culture. And the message here is that obstetrics, as is the case for most medical specialties, is a culture. And I think most of you know that. If you don't, just think about it. We have our own set of beliefs. We have our own set of practices. And in fact, there's a very good book that Dr. Fu Berman lent me that I still haven't returned. And it's available anytime she wants it, but I know she won't ask for it. And it evaluates obstetricians as an anthropologic case study. And the thesis of the author of the book is that obstetricians need to be in control. They need to tell women what position is permitted, whether they can have anything by mouth, when to push. And this need to control is prompted by a fear of childbirth and a need to dominate women. So I think there's a lot to be said for this idea. And in fact, I would suggest that those of you going into healthcare, just keep in mind that fields in healthcare, at least in our society, could be used as an anthropological case study. Now, this is the graduating group of residents. There we are all in the back in 1979. This is at George Washington University. You can see that some of us were cooperative, wearing ties and jackets for the photograph. Others of us were a little more scruffy and unruly. There's the requisite disco chain for 1979. I guarantee you, most of these men also had disco chains, but you just can't see them. The faculty is sitting in front, and you will notice that these are, with one exception, all men. This was the lone woman in our program. So maybe having women become OBGYNs is the answer. Well, fast forward some 30 years. Here is the graduating group of residents at Georgetown University, where I was the program director. First of all, you'll notice no disco chains, but secondly, you'll notice no men. They're all women. So in recent years, obstetrics has been entered largely by women. This is not an exceptional class. Recent classes of entering OB residents consist exclusively or mostly of women. But I'm sorry to say that even as women join the faculty of medical schools in greater numbers, even as women assume the chair of OBGYN departments, and at Georgetown and George Washington, both departments have women as the chairs. The practice has not changed much, if it's changed at all. So I'm prompted to think that women have been emulating the men who taught them, and perhaps we need to wait a few more generations in order for obstetrics to be influenced by the larger proportion of women in the field. All right, I'd like to go to my next topic, which is menopause. I'd like to suggest that menopause is also not a disease. It's also not a single event. Menopause is a transition from a woman who is ovulating approximately once a month to a woman who is not ovulating at all. Ovulation triggers menstruation, and menopause is officially defined as a year without any menses, so it's defined retrospectively. However, for something like a year or more prior to the last period, there are less frequent and more variable menstrual periods. That's a time sometimes called perimenopause. There are issues associated with this menopausal transmission. There are symptoms that occur more commonly in menopausal women. There are diseases that occur more commonly in menopausal women. But I'd like to suggest that menopause is not a cause of these diseases, that in fact these diseases occur as menopause does in women who are getting older. Now, this is a slide, this is a drug company slide used to sell menopausal hormone therapy. And it shows that over time, as years have gone by, the average age of menopause hasn't changed. It's about 50, but life expectancy has increased so that women spend a greater proportion of their life being menopausal. All right, so that's true. So does life end at menopause? Well, probably not. There's a perception that menopause is a time of decrepitude. So here is a premenopausal woman comforting a postmenopausal woman who is shrinking before our eyes. This is the perception of menopause as being a time of galloping decrepitude. But here are some menopausal women whom I don't think you would consider menopausal. This is Hillary Clinton when she was running for president, Margaret Thatcher when she was Prime Minister of Great Britain. This is some nothing actress who won like 800 Academy Awards, but our president doesn't think she's very good. We have Michelle Obama. We have Indira Gandhi in the middle of the bottom row when she was Prime Minister of India, the first and so far the only woman Prime Minister of India. And we have Madonna, whom some of you may not remember, but Madonna was a very important rock star for my generation. And she's still around, so some of you may know her. But there she is. Decrepitude, maybe not. Here's another slide used to sell hormone therapy. But what it shows is the blood concentration of estrogens in women over years that they're alive, showing that at the time of the first menstrual period, estrogens are rising. And then during the reproductive life prior to age 50, estrogen goes up and down with the menstrual period. There are times when it's lower than others, but after this climacteric is the word that they're using here for the whole transitional phase, and this is the last period, estrogens plummet. And the red means, uh-oh, we better do something about this. And of course, the something that is meant by this slide is better give them pharmaceutical estrogens. Well, I doctored this slide a little bit. So here's I put the red stuff around the other side. That is that girls prior to establishing ovulation are in the same red zone as menopausal women, but you don't see anybody saying that we better do something about the hypoestrogenism of girls. We better give them hormones. And of course, we accept the one on the left as normal, but the one on the right gets regarded as a disease. Osteoporosis, which is the tendency or the proneness to fragility fractures, such as this hip fracture, is associated with menopause. But osteoporosis is not just loss of bone mineral, it's also a structural change in the bone. This is an electron micrograph of normal bone, which shows these struts here, keeping everything intact. And this shows how thin these struts have become and how prone they are to fracture. There's a little micro fracture right there. So osteoporosis can be important and it can be serious, but let's take a look at the incidence of fracture in women and men as they age. Aging here, this is white women. They have the highest incidence of fracture. This is Black men. They have the lowest incidence of fracture. And this is Black women and white men. Those curves are practically overlying one another. So do Black women not become menopausal, or do white men become menopausal? Now, as a white man, I certainly have felt menopausal at times, but I think we can accept that it's not just being a woman, it's not just being menopausal. There's something else going on here. Let's look at cardiovascular death, something else that occurs in men and women as they age. So here's the curve for men, here's the curve for women, and you can see that the curve for men goes steadily up. This is cardiovascular death per 100,000. These figures are dated, they're 20 years old, but you get the idea. In women, menopause occurs here. We start to see a bump really there. And here is a comparison of causes of death in women, showing in yellow cardiovascular disease, or rather coronary artery disease, that's heart attack, stroke, and here are some cancers down here, showing that the curve doesn't really do all that much during the perimenopausal period. So that curve right down here is the same as what we're looking at here, but you see a couple of inflection points in much older age women. So this is not menopause. What is this? Well, this is aging. This is aging. So why is it that we blame menopause for the diseases of aging in women? And here's the reason. The reason is we have a treatment for it. We don't have any other treatments for aging, but if we can characterize aging as really just being menopause, we can treat it. So menopause is equated with disease because that model appears to our fear of aging, and because we have ways to prevent so-called aging if you interpret menopause as aging. These are extremely lucrative markets. These are multi-billion-dollar markets. Now, I know, people throw around $1 billion left and right like it's nothing, but I think $1 billion is a lot of money. Finally, I want to say a few words about hysterectomy. Hysterectomy is tied as the most common operation. It's tied with another operation as the most common operation performed in the United States. The tie is with cesarean section.
Tony, make this section short because I want to make sure people have time for questions.
Yeah, no problem. I'm good. So we have only half the population, we meaning OBGYN, but we've got the top 2 surgical procedures. Hysterectomies can be performed for abnormal bleeding. They can be performed for fibroids, prolapse, cancer. I'm only going to talk about the first 2. Abnormal bleeding means the woman or her healthcare provider doesn't like something about her bleeding pattern. It's normal prior to menopause. There's irregular bleeding because there's irregular ovulation. And it can be treated with non-surgical therapies, hormonal agents, non-hormonal agents, or the hormonal IUD. Mirena is the most commonly used brand, but not the only one. And these are photomicrographs of the endometrium, the uterine lining, with the Mirena in place. This shows without it in place, and this is the tissue that's going to bleed. This is the lining tissue. With Mirena, the lining tissue virtually disappears, so there's much less tissue available for bleeding. These are fibroids. They look terrible. These are non-cancerous tumors made out of the same muscle as the muscle wall of the uterus, and they are virtually never malignant. They virtually never become malignant, and they are very common. So in African American women, they're diagnosed in 80% by the time a woman reaches menopause, and white women about 60%. So what that means is if you don't have fibroids, you're abnormal because more women have than don't have fibroids. Fibroid treatment consists of doing nothing most of the time, unless the woman has symptomatic fibroids, or there are other non-surgical methods that can be used. And the good news is that after menopause, the symptoms go away. The uterus gets smaller, the bleeding stops, the pressure gets less or goes away completely. So since Adrian's in a hurry for me to get finished, I'm going to skip the rest of these, which are sort of technical. And I'm going to come to my last question, which is, are obstetrician gynecologists just evil? Why is it that we're doing the wrong thing so much of the time? And I would suggest that the answer is that obstetrician gynecologists are largely not evil, but we certainly have been indoctrinated with a culture, and it can be hard to change a culture. Those of you who grow up to become healthcare providers taking care of women, please keep in mind that there are a lot of things that are normal. Menstrual periods, long labors, menopause, and uterine fibroids. In other words, being a woman is normal. Thank you very much.
That was great, Dr. Scialli.